Hello everyone. Today we're going to be talking about single needle double pump. So what is single needle double pump? Single needle double pump is a unique way of dialyzing a patient where only one needle site is available. In single needle double pump, we use a singular point of access to which a Y site is attached, hence single needle. This Y site allows us to attach the arterial and venous hemodialysis lines to a single point of connection. The single needle is then used to alternate between withdrawing blood from the patient and returning blood that is passed through the dialyzer. If both were to occur simultaneously, we would create recirculation, which would significantly reduce the efficacy of our dialysis. As such, only one pump operates at a time, allowing us to remove and return blood in cycles, preventing this recirculation. This is detailed in the coming slides. Here you can see the two pumps, or double pump, used in this treatment. The right pump is designated as the arterial, whereas the left is the venous. Pictured here is a standard double needle single pump setup. Note that this configuration only requires one pump to fully circulate the blood. Because we have 2 points of access, blood can be withdrawn and returned at the same time, necessitating only one pump. This is the specialized cassette used for single needle double pump. In addition to the regular cassette structure, this setup contains 2 expansion chambers and a venous pump segment. The expansion chambers both store and administer blood pre and post dialyzer, allowing for a nearly constant flow of blood through the dialyzer. This will be visualized in the coming slides. When should you use single needle double pump? Single needle double pump is often utilized when we're unable to get 2 points of access for dialysis. This may occur when we're having needling difficulties or infiltration during dialysis, or if a client has a new AVF not yet suitable for 2 needles with no alternative access, such as a temp or permanent CVAD. Determining when to utilize single needle double pump should be a collaborative effort involving the charge or vascular access nurse, client, and possibly even the nephrologist. When choosing to use single needle double pump, here are some things to consider. Ultrafiltration is not impacted by single needle double pump. You do not have to adjust your UF volume when choosing this procedure. Clearance, however, is substantially reduced. Because only one pump operates at a time, the total volume of blood circulated over the course of the treatment and the pump speed is comparatively low. When one pump is active, the blood is temporarily stationary in the opposite chamber, leading to an increased risk of circuit clotting. This makes heparin-free dialysis more difficult when using single needle double pump. While the circuit size is slightly larger due to the extra pump loops and expansion chambers, the rinse back volume of 300 milliliters remains unchanged. You do not need to account for additional rinse back when using single needle double pump. To better understand this process, let's quickly visualize the full cycle of single needle double pump. I have slowed down the machine footage substantially to demonstrate the steps. Initially, the venous clamp starts closed and the arterial clamp is open. The arterial pump engages and blood is withdrawn from the patient and enters the arterial chamber. It then passes through the arterial pump loop and is mixed with heparin. Unlike with a standard cassette, here the blood passes into the arterial expansion chamber. The expansion chamber is filled while blood also bypasses the chamber and heads to the dialyzer for diffusion and ultrafiltration. After passing through the dialyzer, the blood then collects in the venous expansion chamber. Both the arterial and venous expansion chamber blood levels continue to rise until the single needle pressure maximum is met. More on that later. Once this pressure is reached, the arterial clamp engages, the venous clamp opens, and the venous pump activates. This activation then pushes blood from the expansion chamber onwards to the venous chamber and back to the patient. As this occurs, the action of the venous pump also draws blood from the arterial expansion chamber through the dialyzer. This means that regardless of which pump is moving, blood is almost continuously moving through the dialyzer. This is why both the arterial and venous expansion chamber fluid levels drop when the venous pump is activated. The venous pump continues to move blood until the single needle pressure minimum is met, at which point the venous clamp engages and the cycle repeats. Here you can see a slightly different angle of the same cycle. During single needle double pump, by default, the venous pump will run about 30% faster than the arterial pump. This ensures a rapid return of dialyzed blood before the cycle repeats. Now that you're starting to understand single needle double pump, let's talk about how to set it up. To load the proper cassette, you must first change the treatment type to HD-SN as shown. Confirm the dialysis flow rate and load the single needle double pump cassette according to the machine instructions. The instructions provided by the machine are quite detailed, and I encourage you to follow them closely. Alongside your standard prescription, you must now also set the stroke volume. Stroke volume is the amount of blood passed through the dialyzer, or conversely back to the patient, in one pump activation or stroke. Changes to the stroke volume can be visually observed by watching how much fluid is stored in the expansion chambers during the arterial phase. The higher the stroke volume, the more fluid is stored in the expansion chambers. The stroke volume can be as low as 25 milliliters or as high as 60. By default, the stroke volume is set to 30 milliliters. I typically recommend leaving it here or consulting an experienced practitioner before you start to adjust this. Increasing or decreasing the stroke volume will increase or decrease the duration of the arterial and venous pump phases, and subsequently increase the single needle pressure maximum, although the minimum remains unchanged at 40 millimeters of mercury. The single needle pressure maximum and minimum are what the machine uses to guide which pump to activate. The single needle pressure maximum is the pressure at which the arterial pump phase stops. The single needle pressure minimum is the pressure at which the venous pump phase stops. These pressures regulate the blood volume in the expansion chambers. The single needle pressure maximum varies depending on how low or high the stroke volume is set. However, the single needle pressure minimum is always set at 40 millimeters of mercury and cannot be changed. Here you can see how the single needle pressure maximum and minimum affect our arterial and venous pumps. As the arterial pump turns and the expansion chambers fill with blood, the pressure rises. Once the maximum pressure is met, based on the stroke volume setting, the venous pump engages, draining the expansion chambers until the minimum pressure is met, at which point the cycle repeats. As mentioned previously, the SN pressure maximum is based on the set stroke volume. Here you can see how the stroke volume affects the max pressure. On the left, with a stroke volume of 30 milliliters, the pressure maximum is 161. Whereas on the right, with a stroke volume of 60 milliliters, the pressure maximum is 295. Keep in mind, this is the pressure measured in the expansion chambers. This has no bearing on the pressure of blood returned to the patient. As with standard dialysis, in SNDP it's important to properly set and read your average blood flow. Similar to standard dialysis, the QB or blood flow will indicate two numbers. The uppermost number is the set speed of the pump rotor, whereas the bottom, visually larger number is the actual calculated blood flow. The actual blood flow is the number we record, as it takes into account the cassette being used, rotor speed, pressure, and physical properties of blood. The actual blood flow is typically less than the set speed of the rotor. It takes time for the machine to calculate the new blood flow after a change is made. Always allow at least 2 cycles to recalculate the blood flow, arterial, and venous pressures. Keep in mind your pump speed will always be substantially lower when using SNDP because the pumps must alternate, which limits blood flow per minute. The maximum pump speed for SNDP is 210 milliliters per minute. I've never seen anything close to this pump speed, as the arterial and venous pressures are typically the limiting factors. There is no definitive best pump speed. Consider the state of the access, whether it's a new AVF or experienced needling issues. Watch your pressures, and if necessary, consult an experienced practitioner or nephrologist to assist in setting the pump speed. Ideally, make gradual pump speed adjustments and let your access pressures be your guide. Because only one pump is active at a time in SNDP, you're only getting relevant pressures for that pump. When the arterial pump is active, you will see current arterial pressures. When the venous pump is active, you will see current venous pressures. The pressures will change and stabilize as the pump activates and gets up to speed, so it's important to wait for your pressures to stabilize rather than taking a reading right after the pump activates. Because you can only record pressures for the pump that is currently active, taking pressure readings takes substantially more time than with double needle, double pump setups. When changing your pump speed, make sure to do so in small increments and then wait at least 2 cycles to ensure the pressures are stable before increasing the pump speed further. Because your venous pump is moving about 30% faster than the arterial, your venous pressure will likely be your limiting factor. Pressure limits of a standard treatment apply. Pressures must not exceed negative 250 millimeters of mercury for arterial or 250 millimeters of mercury for venous. That being said, I typically like my pressures well within those safeguards, as we're typically running SNDP with a new vessel or one that's experienced needling issues. In some cases, the SNDP cassette is chosen due to the difficulty of the accession or the fact that the vessel is new and the nurse is uncertain if 2 needles will be viable. Despite using the SNDP setup, if you're able to get 2 points of access, you can easily switch to double needle, double pump. If you've not yet connected the patient, you can do so by selecting the prescription button, finding treatment in the upper left, and selecting double needle. If your treatment's already been initiated, simply select Special Procedures, switch to DN. After performing this switch, both pumps will turn simultaneously, and the treatment will be the same as using a standard cassette. You don't need to program the stroke volume, and other than the additional expansion chambers being present, there are no extra considerations. Proceed as you would normally with a double needle, single pump setup. If necessary, you can also revert back to single needle, double pump in the same manner. Thank you so much for watching this video till the end. I hope you enjoyed it and found it informative. I didn't want the video to be overly complex, so I tried to highlight just the key points, but if there's any additional areas you'd like me to expand upon or you have any questions, please don't hesitate to reach out. Thanks so much, and I hope you have a great day.